Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on considerations for maternal weight gain, featuring Dr. Milena Murray from Midwestern University College of Pharmacy and Northwestern Memorial Hospital in Chicago, Illinois. She'll take us through a case study of a pregnant patient on antiretroviral therapy, and we'll explore the latest data about maternal weight gain associated with antiretroviral therapy use in pregnancy, including pregnancy effects and the role of baseline maternal weight. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Murray.
Welcome to Key Decisions in HIV. Our topic today is considerations for maternal weight gain. My name is Milena Murray, and I am an associate professor of pharmacy practice at Midwestern University College of Pharmacy at the Downers Grove campus and an HIV/ID clinical pharmacist at Northwestern Memorial Hospital. Our case patient is a 27-year-old woman presenting to an HIV follow-up appointment who reports she is 12 weeks pregnant. She has seen her OBGYN to confirm pregnancy and has received all appropriate prenatal care up until this time point. Her HIV is well controlled on an antiretroviral regimen of dolutegravir with emtricitabine and TAF, and the patient reports that she is tolerating this regimen well. Her labs are on the right side of the screen. Her CD4 count is 652, and she is currently undetectable. Of note, again, her BMI is 32. So our question is, what is the concern with the patient's baseline weight or gestational weight gain with this particular regimen, and do we need to switch her antiretroviral therapy? I will note throughout the presentation how baseline weight and gestational weight gain should be analyzed separately. The IMPAACT 2010 study included 643 pregnant, antiretroviral therapy naive women with HIV beginning at 14 to 28 weeks gestation. Participants were randomized to one of three arms, either dolutegravir daily with emtricitabine and TAF daily, dolutegravir daily with emtricitabine and tenofovir disoproxil fumarate or TDF daily, or efavirenz, emtricitabine, and TDF daily. Safety and efficacy outcomes were assessed through 50 weeks postpartum, and maternal weight gain was also evaluated. Viral suppression was significantly higher in people on dolutegravir-based antiretroviral therapy versus the efavirenz-based therapy. When looking at dolutegravir plus emtricitabine and TAF, there were significantly less adverse pregnancy outcomes compared to dolutegravir with emtricitabine and TDF or the efavirenz-based therapy. The same trend was seen with neonatal deaths. These outcomes may have been better with dolutegravir plus emtricitabine and TAF because this particular arm was the closest to the recommended amount of weight gain during pregnancy. These graphs show the average weekly weight gain versus the antiretroviral regimen on the top and a categorical breakdown of percent of patients with low, normal, and high weight gain by ART regimen on the bottom. The average weekly weight gain was highest with dolutegravir when it was with emtricitabine and TAF. Both insufficient and excessive weight gain during pregnancy were associated with adverse outcomes. There was a significant association with a higher average weekly weight gain and a lower risk of adverse pregnancy outcomes across all of the treatment arms. In the normal weight gain category of the bottom graph, you can see that the dolutegravir plus emtricitabine and TAF arm had the highest number of patients with normal weight gain. Looking at the top graph, we can see that all regimens were actually below the recommended weight gain in pregnancy. These graphs compare the average weekly weight change to maternal weight change through 50 weeks postpartum, and then the percentage of women with a BMI 30 or greater at 50 weeks postpartum. Both graphs are categorized by antiretroviral regimen. There was a significantly greater weight loss with efavirenz, emtricitabine, and TDF versus dolutegravir-based regimens. And there were more women with a BMI 30 or greater in the dolutegravir plus emtricitabine and TAF arm. The SMARTT study was a 12-year observational cohort to evaluate the association of antiretroviral classes with gestational weight gain in a little less than 1,500 pregnancies in people with HIV. Everyone in the study was taking at least 3 antiretrovirals and started at less than 16 weeks gestational age. The table lists timing of antiretroviral therapy class, and the adjusted risk ratio for gestational weight gain. In this study, INSTI-based therapy was the reference category and was not associated with excessive gestational weight change in this cohort. The analysis adjusted for self-identified race, ethnicity, age of delivery, annual household income, earliest viral load in pregnancy, any substance use in the first trimester. In the Tsepamo study, maternal weight and birth outcomes were studied in women who had been taking antiretroviral therapy since conception. They analyzed data in approximately 4,500 singleton deliveries with weight data available at 12 and 24 weeks. They looked at an association between baseline weight and weight gain on pregnancy outcomes. There were several key findings from this study. Gestational weight gain did not have a substantial impact on outcomes, except for a risk of fetal macrosomia with high gestational weight gain. Women with a lower baseline weight were at an increased risk of severe birth outcomes, such as preterm birth, small for gestational age, or perinatal death. A higher baseline weight was associated with the risk of macrosomia, as well as maternal hypertension. When comparing dolutegravir to efavirenz, there was a higher gestational weight gain with dolutegravir and more maternal hypertension. Overall, the effects of antiretroviral therapy-associated weight gain are very diverse and depend on the maternal baseline weight. This table shows the baseline weight categories as low, moderate, or high in the antiretrovirals used. As you can see in the table, there was a diverse population at baseline and more women with an efavirenz-based regimen. Again, baseline weight should be considered separately from gestational weight gain. There were several women in the less than 50 and greater than 90 kilogram categories. Overall, this baseline weight was similar between dolutegravir and efavirenz. The prevalence of maternal hypertension increased among women on dolutegravir versus efavirenz across all baseline weight categories, and this was significant when adjusted for the antiretroviral regimen as an effect modifier. When looking at baseline weight changes, the table on the right, the median baseline weight increased significantly for dolutegravir, which was 64.4 versus 62.5 kilograms, while it remained stable in those taking efavirenz. The prevalence of any severe birth outcome for women with baseline weight greater than 90 kilograms was greater for dolutegravir versus efavirenz, but this was not significant in an adjusted analysis. When we look at the DHHS guidelines, studies have shown a greater weight gain with dolutegravir-based therapy compared to efavirenz-based therapy. However, women on both of these regimen types had less weekly weight gain than women without HIV and less weekly weight gain than that recommended for the general population. When looking at postpartum weight gain, several studies, including the Dolphin-2 study, showed a greater postpartum weight gain with dolutegravir versus efavirenz and a similar weight gain to women without HIV. Overall, dolutegravir-associated weight gain may reflect better maternal health as evidenced by lower rates of insufficient weight gain or weight loss during pregnancy. Based on the recommendations in these guidelines, it would be unlikely that we would switch a regimen in a patient who is stable only due to weight concerns, such as the patient in our assessment question. So for our take-home points in studies, significantly greater gestational weight gain was seen with dolutegravir-based therapies when compared to efavirenz-based therapy. However, again, all of these weight gains were below those weekly recommended weight gain in the second and third trimesters. And low gestational weight gain has been associated with adverse pregnancy outcomes. Gestational weight gain was higher with dolutegravir than efavirenz, regardless of the patient's baseline weight. And higher baseline weight was associated with an increased risk of macrosomia as well as maternal hypertension. And this maternal hypertension was higher with dolutegravir than with efavirenz-based therapies. So overall, antiretroviral-associated gestational weight gain will have diverse pregnancy effects, mostly depending on what the maternal baseline weight actually is. Thank you for joining us today for this key decision in HIV care. Medical minutes and podcasts with expert faculty, clinical thought commentaries from physicians and patients, and patient education sheets to print and share are all available on clinicaloptions.com/HIV.
Thank you to Dr. Murray, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.